Here is your station.
Yes, I'm ready.
Okay. So if you've read and understood, considering it communication skills station, please begin.
Hello,
Yes, hello.
I'm Dr. Ali Bade, SHO doctor working for Mr. Mann in Manchester Hospital. I'm calling to speak to the on-call consultant. Can I check that I'm calling to on-call consultant?
Yes, go ahead. I am
Yes,
Dr. Maher, yes, the on-call
yes.
consultant.
I'm calling you to ask you advice about. I'm quite worried that he developed post-operative oliguria. Okay,
Yes, go ahead. Okay.
Okay, I review a lady, 69-year-old, post-operative day one. She underwent right hemicolectomy for cecal tumor plus liver biopsy. And I review her in this morning. I check the urine output. It is only 20 ml per liters, and she is receiving only 111 fluid,
1100. Yes.
1100 of normal saline in the last 24 hours. The abdominal examination, the abdomen is lax. Patient is tachycardic, hypotensive, and the blood investigation, the hemoglobin show drops from 12 to 10, and the uric creatinine is rising. The ECG is normal, and the chest X-ray is normal. Based on this, I would like to start fluid resuscitations, close monitor the patients, and I will considering HDU admissions. Would you like me to proceed with this plan, or do you have any additional concern?
Okay, Dr. Ali, could you please tell me what do you think is causing this in the view of
Uh,
her clinical data? Yes.
yes, this is most likely due to dehydration because patient receive minimal amount of fluid in the post-operative day one, and also intraoperatively there is minimal uh, loss of blood, but patient receive 2 units of blood intraoperatively.
So why could you tell me why creatinine is high?
This is due to dehydrations causing the vasoconstrictions leading to the tubular necrosis.
Okay, and so what will be your plan of action? What you will do?
I will start the fluid challenge by giving patients 250 to 500 ml of normal saline in 15 to 30 minutes. And I will repeat this for 4 times if there is no response.
Okay, and if no response to fluid challenge overnight, what you will do?
I will call you back, and I'm calling the HDU registrar to refer patients to the HDU for central venous lines, considering blood transfusions according to hemoglobin level, and also for inotropes.
Okay, and how will you monitor this patient response to the fluid challenge?
Yes, by capillary fill times, blood pressures, mental status, and urinary output.
Okay, good, very nice. And do you think that the patient is bleeding?
Maybe, but for now, I will monitor patient's serial abdominal examination. And if I found that any sign of intra-abdominal bleedings, I will let you know.
Okay. And what are the signs of hypovolemia, and how you could know that there is bleeding?
Yes, there is persistent hypotension and tachycardia, and patient is not responsive to the fluid resuscitation, and there is a continuously dropping in the hemoglobin level.
Okay. And do you think this patient is having an anastomotic leak?
Leak, one of my differential diagnosis, but for now the abdomen is lax. I will continue monitor the patient with the serial abdominal ultrasound to look for any collections. If I found that patient become toxic and peritonitic, I will update you.
Okay, and do you need me to come and check the patient?
For now, no need. I will just start fluid resuscitations and I will repeat it after 4 times. If there is no response, I will call you again.
Okay, and does the patient require HDU transfer now?
For now, no, but if patients, there is no response after repeating the fluid channel after 4 times, this patient need close observation in the HDU.
Okay, and does she require operation now?
For now, no need. Just I will start the fluid challenge and monitor patient hemodynamically. And then if any change happened, I will let you know.
Okay, and if the HDU is full, how are you going to speak to the patient? Oh, and who are you going to speak to, and what you will do?
I will speak to the bed managers. I will talk to him about the importance of my case to discharge the most stable one or repartitioning of the patient.
And do you think the patient is shocked?
Yes.
So what type of shock and what are the causes of shock in this patient?
Hypovolemic shock, maybe septic shock.
Okay. And what to do if fluid challenge? What to do fluid challenge for him, for her?
Yes, I will give patients 20 ml per kg as a bolus dose.
Okay. And is that patient when he need hemodialysis?
For now, no, there is no indication for hemodialysis.
And what do you think the indication for hemodialysis?
Severe acidosis, pH less than 7.2, and intractable hyperkalemia, potassium more than 60.5.
Okay. Okay. Could you please summarize our plan?
Yes, I'm calling you about this patient. He developed postoperative oliguria. I will start fluid challenge, giving patients, I will repeat fluid challenge for 4 times. If there is no response, I will consider to admit patients to the HDU for blood transfusions. Also, I'm going in the morning, I will take a new set of blood to check hemoglobin's level. All this.
Okay. 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 Give me update, please. Thank you very much.
Yeah, one last question. If all of a sudden patient saturation drops, what would you suspect and how would you manage it?
I suspect there is a pulmonary embolism.
Very good. And
Uh,
how would you proceed to manage it?
yes, I will give patients immediately. I will start heparin dose, therapeutic dose.
Yes.
And then
And
I'm going to for investigate the patients.
with CTPA.
TTPA, yes.
Yes. Heparin and TED stocking.
Yes.
TED stocking. Very good.
Yes.
Excellent. Excellent. Good. Thank you.